The reason for that is that there has been a lot of lack of awareness about pediatric endocrine disorders. So we started off with workshops and practical courses which were held across the country. Then we realized that it was very difficult to cover large areas because it is so much logistically difficult. So we started off with social media, particularly with YouTube. And then we started our fellowship program. Now we have got, today we have now got around 10th fellow. Dr. Dhwani has joined as well. So we have got now 10th fellow in our system who has joined the CDR program. Then we started off with our online courses and then finally textbooks and mobile applications. So we have tried to take forward in terms of making it easy and easily available and accessible in that regards. We have conducted a number of courses. The first practical pediatric endocrine course actually happened 10 years ago. So since then, we have got a lot of physical programs, but we also now have a lot of online programs which are there. So this is the third online program which we are doing because this provides a much wider access across the globe in that regards. We have our YouTube channel, which has got large number of videos which provide information about every aspect of pediatric endocrinology. There's also an online course which covers various aspects using validated tools. And we have got special courses, including the pediatric endocrinology for fellows, for postgraduates, fellowship in pediatric endocrinology, and a number of programs which are available online, which you can access through our website. We also run routine, regular postgraduate lecture series along with grand rounds using specific cases. So all these are concised in around 8 hours. These ones will run a long time and cover the entirety in that perspectives. And we have got publications which you can access and our mobile application, which will also showcase how it helps in terms of making point of care assessment and diagnosis possible. We are in the process of developing and probably will launch soon about our personalized intelligent EMR, which will allow our overall aspect of care using minimal inputs. Patients will get detailed output with regards to the likely diagnosis, likely evaluation and management. This will make connected clinics through using the e-system, making it much easier to whatever has been learned to implement in that regard. So recently, we have got a lot of programs. People have joined the fellowship program and the diploma program as well. So coming specifically on this International Practical Pediatric Endocrine course, we have got this 2-day program. First day is dedicated today on office endocrinology. We'll be covering growth, thyroid, puberty, and DSD. And tomorrow, we're going to cover the endocrine emergencies, mainly calcium, electrolyte, decay, and hypoglycemia. So 8 modules. Dr. Vidhu Ashok, who is from Malabar Medical College, Calicut, and Dr. Pragya Somani from Bhilwara. And all of them have been actively involved in terms of our programs as well as the other participation which is there. I'll also be joined by Dr. Vibha, who will be moderating the session after we had the initial discussion in that regard. So when we talk about electrolyte disorder, we need to remember that both sodium and potassium play a very important role in electrolyte regulation. And when we talk about tonicity, the sodium is a major regulator of the tonicity, while water will depend upon the volume. So when we talk about the sodium level, we have to look at how much sodium is there and how much free water is there. Most disorders of sodium are actually because of free water. If you have too much free water, you have hyponatremia. If you have too little free water, you will have hypernatremia. And this is regulated at the level of thirst and urine output. Now, this basically regulates using the water intake and how much water you are losing. Now, in conditions where your tone increases, the body will then start to have stimulation of the secretion of vasopressin, because that will be sensed by the osmoreceptor, and this vasopressin will then cause conservation of water, free water, and this will restore the status. So AVP is a highly sensitive hormone which works at a very 1% change. You will have a modification which are there in that perspective. However, if your volume goes down, the major regulator there is the renin, angiotensin, aldosterone system, which will then cause our absorption of sodium in competition to potassium. So RAS basically causes high sodium and low potassium. So if you have a RAS deficiency, like any form of hypoaldosteronism, pseudohypoaldosteronism, adrenal insufficiency, you will have hyponatremia with hyperkalemia. That's a predominant finding that you will find on that. However, if your volume becomes too much, the atrial natriuretic peptide comes into the picture, and that will cause a loss of sodium. And therefore, anybody who has a long-standing hyperaldosteronism will not have hypernatremia. Main presentation will be hypokalemia and alkalosis in that perspective that becomes important. Now, potassium is not only in the extracellular fluid, predominantly it is in the cell. So conditions which cause exchange of potassium with the intracellular homeostasis can cause a hypokalemic picture, particularly with hyperinsulinism, that we will discuss in treatment of DKA along with the use of beta agonist in that regards. Now, serum sodium, when we are assessing it, should ideally can be done any time of the day. But remember that if somebody had seizures, you will have a lot of muscular activity and the sodium may falsely go up. So you have to be careful. Don't use that particular arm. Very importantly, if you have a hyperproteinemia, hyperglycemia, or hyperlipidemia, you will have pseudo hyponatremia. Now, in hyperglycemia, this will persist even if you are using an ion selective electrode, because it is not pseudo in the truest sense, it is dragging more water out. You will have high levels if the albumin level is on the lower side in that regards. Normal sodium is 135 to 145. And if it's less than 130, we consider worried about hypo. And if it's more than 150, about hypernatremia. Now, potassium is typically an intracellular ion. Again, you can do any time of the day. But remember, don't use a hemolytic sample. So don't squeeze it and avoid using syringe. Definitely, tourniquet should actually be avoided in that perspective, and don't keep it for a long time, because then the RBCs will lyse and they will increase the potassium level in that regards. You may have pseudo hyperkalemia if there is hemolysis, or if you have a high count like leukemia, they will all consume the potassium and you may have falsely low level of potassium. So all this becomes important in terms of evaluation. The blood gas, as discussed, is not a very reliable marker. It will typically lower by 0.4 millimoles compared to the serum sample that we are using in that regards. So be cautious about tourniquet, squeeze sample, and high cell count in that regards. Now, this is very interesting. Normally, we talk about this interplay. We said calcium and phosphorus. We said if calcium goes up, phosphorus should go down. If calcium goes down, phosphorus should go up. Similarly, when we talk about sodium and potassium, generally, if the sodium goes up, like aldosterone is high, potassium should come down. When sodium comes down, potassium should go up. But if you have hypernatremia with hypokalemia, this is a typical scenario. This is a RAS excess. Now, as I said, the sodium excess is not going to be huge because atrial natriuretic peptide will come into the picture. It will wash off the sodium. If you have hyponatremia, you will have hyperkalemia. This is typically a scenario of a RAS defect. This is pseudo-hypoaldosteronism, hypoaldosteronism, adrenal insufficiency, all those phenomena will be there. But if you have a rare situation of high sodium, high potassium, only one condition, remember, is Gordon syndrome, rare scenario. If you have low sodium, low potassium, you're losing it either via the gut, so you have diarrhea, or via the kidney because of tubulopathy or diuretic use. So if you want to really look at the sodium potassium together, you will get a lot of information in that perspective. So hyponatremia can usually be because of excess free water. In that scenario, the individual will be Q or hypervolemic and uric acid will be low. Now, uric acid excretion depends upon the amount of water in the body. If you have more water, more uric acid excretion, less uric acid. So uric acid is a good marker of hydration. If you have a sodium loss, on the other hand, you will be hypovolemic with high uric acid. Now, excess free water can be because of overload. You will have edema, cardiac, renal, all those causes will be there, and you will have a low urinary sodium. Or if there is a reduced loss of free water, typically because of SIADH, you will have a situation in which the urinary sodium will be high. Now remember, SIADH-like picture can also be caused by cortisol deficiency and hypothyroidism. So SIADH is a diagnosis of exclusion. Don't rush anybody with euvolemic hyponatremia. Don't call them SIADH. You have to look at other possibilities. Now, if you talk about sodium loss, it can be extra-renal. In that scenario, the body will conserve the urinary sodium, or it could be renal where your urinary sodium will be high. A scenario could be again with tubulopathy, like diuretic use or other scenario versus RAS defect. To differentiate this, you will have hypokalemia in this scenario and you will have hyperkalemia in RAS defect. So basically, if you look at the key things, fluid status, the potassium status, and urinary sodium, you will know entirely everything about hyponatremia etiology. So if uric acid is low, which means you have fluid overload, it is either SIADH or fluid overload. If you have a low urinary sodium, it means it's a extra-renal cause which you have to worry about. If the potassium is high with hyponatremia, you are dealing with a RAS defect or renal failure. And if hemoglobin again is a marker of volume status. So if you look at these parameters, you will make a correct diagnosis. So to approach hyponatremia, first rule out hyperglycemia, hyperlipidemia, hyperproteinemia, and renal failure. Then look at volume. If volume is more, this is fluid overload. If volume is normal, look at thyroid and cortisol. If that is normal, this is SIADH. If there is hypervolemia, look at urinary sodium. If the urinary sodium is low, this is extrarenal loss like GI loss, cystic fibrosis. If it's more, look at potassium. You have hypokalemia, this is tubulopathy or diuretic use. If you have high level, this is a RAS defect. So first look at volume. If volume is euvolemic, look at thyroid and cortisol. If volume is low, look at urinary sodium and potassium. You will basically get the diagnosis.
700. And his sodium was 126, which is hyponatremia, and potassium was 3.6. And the blood gas shows acidosis. So, Dr. Kamlesh, what should be done? We should correct the hyponatremia in this case?
No, thank you, Dr. Viva. Actually, we have to first rule out whether it is true hyponatremia or it is pseudo hyponatremia. As Dr. Anurag sir already told us that pseudo hyponatremia can be caused by either increased lipid level in the blood or increased protein level or increase in the glucose level. And iron selectors cannot identify that hyponatremia due to hyperglycemia. As in our case, we have a child who have blood sugar is 700 milligram per dl, which is quite high. So we have to calculate the corrected sodium level. And as we know that every 100 milligram rise in the blood sugar level above 100 milligram per dl, there will be fall in the serum sodium level of 1.6. So we have to calculate the serum sodium level of 1.6 into 126. So it will, and then it will be 135.6. So the corrected sodium concentration will be 135.6. That is normal for the for this child.
Right, sir. So what key message would you like to give from this case?
So the key message is that before starting any treatment in a hyponatremia, we have to first calculate the corrected sodium level. Whether it is true hyponatremia or pseudo hyponatremia, we have to rule out.
Thank you, sir. Very rightly said by the sir. We should not rush to the diagnosis of hyponatremia in cases of high blood sugar. We should get the corrected sodium done first. So now moving towards the next case, we have this 1-week-old boy with the low sodium, that was 128, and with the lower side of the potassium 3.6. So Dr. Suvarna, how should we move in this case?
Thank you, Dr. Bibha. An interesting scenario. So as we just learned, we should always look at the fluid status of the baby to make a diagnosis. So I would like to ask, is the baby hypovolemic or dehydrated, or when you just...
Ma'am, there was no dehydration. The hydration was well maintained.
All right. So there's no dehydration. So I would assume that it's a case of euvolemic hyponatremia. As we have learned, again, as per the protocol, we should always look for cortisol and thyroxine, but you have already given me a sugar value of 24. That's and ketotic hypoglycemia picture we can see here. So I would really like to know the cortisol level in this case, please.
Ma'am, when we got the cortisol level, it was 125. So what do you think? This cortisol level is going with this sodium level?
No, this is very important actually. So this cortisol level is actually inappropriately low for this level of hypoglycemia and hyponatremia. This is a very important point that we should always note and so interpret the results accordingly in the light of the other results. And I can also see you've given that the growth hormone level is also 4. So right. I can see there are 2 already, hormonal deficiencies we can already gather there. And you've already given me a photo.
There is also in the picture, micropenis is also there.
Yes, so that kind of completes the diagnosis. So important to look at the baby clinically and also look at the biochemicals and interpret them properly. So in this case, baby with the micropenis and hypoglycemia, hyponatremia, with inappropriately low cortisol and growth hormone, I think it's a case of hypopituitarism, pan-hypopituitarism. So very interesting case actually, and I would really like the listeners to note that we often get such cases of hyponatremia in babies, and instead of overlooking that or not exploring that, we should always send, especially in case of euvolemic case like in this one, we should always send for cortisol levels and thyroxine, and also interpret the levels, cortisol levels, in the light of the other report. So for this level of hypoglycemia and hyponatremia, this cortisol is definitely low and should not be considered as normal.
So, ma'am, what message would you like to give?
Yeah, so as I said, in all cases of euvolemic hyponatremia, so we know that the child is not dehydrated, there is no vomiting, diarrhea, nothing else going on. So cortisol levels should always be sent here. And cortisol levels below 550 nanomoles per liter should be considered as low.
Thank you so much, ma'am. As ma'am already mentioned that the volume status is very important in case of hyponatremia, and it gives us a clue in which direction we are moving towards.
And especially, I would also like to say that the implication of such a diagnosis, you see, MPHD, isn't it a lifelong diagnosis? And this can be made at such an early stage. So it's very important. Yes, thank you.
Thank you so much, ma'am. So moving towards the next case, we have this 14-year-old boy who was brought to the hospital because he was having some drowsiness, and we get the sodium level done. It was quite low. It was 116 only. When we examined the baby, the hydration status was good. The hydration was well maintained. When the urinary sodium was done, it was 100, and the urinary osmolality was 300. So the diagnosis of SIDH was made in the emergency, and fluid restriction was done. So, Dr. Vidhu, what do you think? Are you satisfied with this diagnosis of SIDH, and is this fluid restriction is judicious in this case?
First, I would like to thank for the Anurag sir for the special opportunity, and Dr. Vibha for moderating our cases. So now we have come with a boy who has drowsiness, whom we have noted to have hyponatremia, and we can see that he is euvolemic. And we can see that the urinary sodium is also low. So it's like we are thinking in terms of SIADH, but sir has well explained that SIADH is always a diagnosis of exclusion. So before tagging the patient, we have to ideally check the cortisol status. It's like an extension of the case which I've already discussed. So it's like we have to check the cortisol and also the thyroid status of the patient, free T4 and TSH. And, oh yeah, okay.
So, ma'am,
so the values.
When we get the thyroxine cortisol level done, the T4 was 2 and the cortisol was quite low. It was 120 only.
So again, this is another case, like there is multiple pituitary hormone deficiency. Like the before case, even in this case, what we have to understand is that SIDH is a case, it is a diagnosis of exclusion. So before tagging or doing fluid restriction, we have to look into, when it is euvolemic, we have to look into the cortisol levels as well as the thyroid status. So that is almost like the key message for this question.
Okay. So the key messages ma'am have already given, that SIDH is a diagnosis of exclusion, and we have to always get the cortisol and free T4 level done in the patient of euvolemic and hyponatremia. Thank you so much, ma'am. Now moving towards the next case, we have a 3-week-old child, and he came to us for the failure to thrive. When the sodium level was done, it was 110 only, and he has only gained 100 grams in 3 weeks. Was severely dehydrated. Hematocrit was 62, urine sodium was 100, and potassium, hyperkalemia, there was 8.4 potassium was there. So Dr. Pragya. Hello, ma'am.
Hello.
Dr. Pragya, okay.
Yeah.
So ma'am,
can you hear
how
me?
should we proceed this case?
So as we can see in this case, it's a hypovolemic child. No? PCG is raised, so this is a hypovolemic child with a urine sodium which is on higher side.
Right.
And there is hyperkalemia. So this would point toward a RAS defect.
And ma'am, when we examined the child, there was atypical genitalia.
Yeah. So these atypical genitalia point towards a defect in the steroidogenic pathway, most likely. Did we get 17 OHP done in
Yes,
this?
ma'am. We sent the 17 OHP test and it was 200.
So this is a raised 17 OHP. This seems to be a classical congenital adrenal hyperplasia, which is a result of the salt wasting type, which is resulting in these symptoms.
Right, ma'am. So, ma'am, what key message would you like to give?
So the key message is that in hyponatremia with hyperkalemia, a RAS defect should be considered. And in case of atypical genitalia, in case we see atypical genitalia, this points towards a CAH. But in males, as there will be no features in males at birth or at the 3 weeks of age, so we have to be more cautious in males. We should not overlook these symptoms of hyponatremia and hyperkalemia, as this can be a life-threatening situation.
Thank you so much, ma'am. Now, moving towards the next case, we have this 6-month-old girl who was diagnosed with cystic fibrosis as she was not gaining weight and she was having recurrent chest infections. When the sweat chloride test was done, it was 120 and there was no history of steatorrhea. Her sodium level was 120 and there was hypokalemia. So, Dr. Kamlesh, what do you think is the diagnosis of cystic fibrosis? Are you satisfied with this diagnosis, or
no,
are
no, I am not satisfied with
something else?
Yeah. In cystic we are not satisfied with the diagnosis of cystic fibrosis because, as we know, in the cystic fibrosis, there is the electrolyte abnormality is hypokalemia and hyponatremia with metabolic alkalosis, and this child has no steatorrhea also. So we have to look for the as the child has hyponatremia with hyperkalemia, we have to look for the RAS serum urinary sodium level, and urinary sodium level is more than 120 millimoles per liter. Then it indicates the RAS defect, and we have to look for the plasma renin activity and aldosterone level. And if they are high, along with hyponatremia and hyperkalemia, then we with recurrent chest infections, we have to think about the pseudo hypoaldosteronism type.
Yes, sir. We did the urine sodium in this case, and it was 120, and both the renin and aldosterone level was high.
So, Bima, why did this child have respiratory infections?
So, because this, because as we know, there is a resistance to this innate channel. There is a defect in the innate channel and the pseudo hypoaldosterone. This innate channels are also present in this sweat gland. So, this this is innate channel also present in this bronchial alveoli. That's why they are more prone to have respiratory infection.
And this is a very difficult scenario. We have had a girl who required multiple admissions because their secretions are very, very concentrated. And that's why they are not able to expel. So whenever they have an infection, their infection tends to be more severe. So this is often misdiagnosed as CF. But even if you're diagnosed as pseudo-hypoaldosteronism, you have to be very cautious in this scenario because they will develop this blockage of secretion.
Yeah, so it's like, it's so badass. It's so badass.
Dr. Kamlesh?
Yes.
Okay.
Hello.
Sir, what key messages would you like to give?
So we have to always, any child who has presented recurrent chest infections along with hyponatremia and hyperkalemia or salt wasting, we have to think about the pseudo hypoaldosteronism.
Right, sir. So any patient who is having this salt wasting and recurrent pneumonia, it is not cystic fibrosis. We have to keep in mind that it could be pseudo hypoaldosteronism, as sir has rightly said. Thank you so much, sir. Now moving towards the next case, we have this 1-month-old boy who came to us because there was a refusal to feed. And this boy has gained only 100 kg in this 100 grams, in this 1 month. And they showed that the blood sodium level was 124 and there was hypokalemia. So in the view of this, the boy is not taking feed and there was lethargy, there's salt wasting like symptoms also. So we get the 17 OHP level done. It was normal and cortisol was high. So, and we get the aldosterone level done, which was on the higher side, and PRA was also on the higher side. So Dr. Sumarna,
Yes, yes,
could
Dr.
you help us with this case?
Yes,
the
sure.
patient is this behaving like a salt wasting, and but the 17 OHP and cortisol is normal. So what scenario we are dealing with?
Right. So 1 month old boy, as we can see, with failure to thrive, not has suboptimal weight gain, hyponatremia, hyperkalemia, simulating CH like scenario. However, we have everything ready at hand. You have done a fantastic job so far, Vibha. So 17 OHP is normal. Cortisol is appropriately high here. And of course, PRA and aldosterone are high. So this is, although despite hyponatremia, this is a situation of like aldosterone resistance. So aldosterone is high, but we are still having hyponatremia. So I think there is something else going on. With the history that you gave, it seems the baby is having some sort of an infection because of reduced feeding and lethargy. Can you give me some more information in terms of any other urine test that you did or anything like that?
Considering this infection, we sent the urine routine. And we found that it showed greater than 100 pus in the urine.
There you go. So we have a full-blown urinary tract infection there. Very common scenario that we get in the neonates, actually. I mean, not too uncommon, I must say. Did you do an ultrasound too?
Yes, ma'am. The ultrasound showed there was an obstruction in the urinary tract also.
Right. So a very, very interesting scenario, and should not be forgotten that in this kind of situation where we get pseudo like aldosterone high but hyponatremia, we should in this kind of age group, we should always rule out tubulopathies and obstructions, anomalies, and rule out UTI, because it has been seen that in these cases there is a transient pseudo hypoaldosteronism like picture which responds brilliantly to the treatment of the primary cause, that is the infection. So here, because there is an urine infection going on, once the baby is treated for urine infection, this thing will totally, the electrolytemia will be corrected and the baby will get better in no time. This is very, very important. I mean, we have got many articles. If you look at them, they have shown that very typically PUV, posterior urethral valves, vesicular reflux, and all those things have been seen to be associated with this kind of transient PHA3 like picture, actually.
So, ma'am, what key messages would you like to give?
Yes, so again, we should always rule out the common causes like infection, UTIs, and sepsis, which might cause a transient pseudo hypoaldosteronism like picture before embarking on further management, because it is a very, it has good prognosis and response promptly with treatment.
Thank you so much, ma'am. Like ma'am has said, sometimes a very simple investigation like urine routine microscopy can help us very much. So now moving towards the next.
So just before we start with regards to the further aspect of hyponatremia, just the treatment of hyponatremia, it depends upon the duration and the symptoms. So if you have somebody who has got a recent onset scenario and the child is symptomatic, you can then give a rapid correction. Remember, if you raise the sodium levels very rapidly, you may cause cells to shrink. They are already swollen, but then there is an effect of idiogenic osmosis which cause them to maintain a normal shape. But suddenly, if you push a lot of sodium, it will cause shrinkage and there will be osmotic disequilibrium syndrome. So unless there is acute severe hyponatremia, do not give 3% saline. In this scenario, you can give 3% saline to raise the levels. If you have mild to moderate, you can then give a low dose and follow up. If it is above 48 hours, generally be a bit more cautious. In that scenario, you only give 3% saline if there is a coma or seizures. So again, depending upon the symptomatology, you decide what correction is to be given, and then you don't want to raise the sodium at a very rapid rate. Typical rise will be around 6 to 8 millimoles per liter per day. Moving on to hypernatremia. Now, hypernatremia could be because of either reduced free water Because water is less, that is because of reduced intake like neonate typically or edipsia, or increased loss, which could be extra-renal because of sweating. So we see a lot of people in high temperature, they can have this scenario, or diarrhea, in which all these scenarios, your urinary sodium will be on the lower side and you will be dehydrated. Or you have a renal loss in which you have a problem in ABP production or resistance. So now you have central or nephrogenic diabetes insipidus. On the other hand, you can rarely have sodium load, which is extremely uncommon. So as discussed, hyperaldosteronism does not cause hypernatremia because the ANP comes into the picture. And exogenous cause, of course, if you have an inappropriately produced ORS, that can cause this scenario. Here, your urinary sodium will be high. So the most important investigation in a child with hypernatremia is urinary sodium. That will give you an important clue and you will identify the picture. So the approach is you rule out the common causes like salt load, mannitol use in diabetes. Look at urinary osmolality. If it's low, hypernatremia with low urinary osmolality is DI. Do not go for water deprivation test, the child will die. So in that scenario, you look for AVP response present, it's central DI, absent, it is nephrogenic DI. If urinary osmolality is high, then DI is excluded. Look at urinary sodium. If it's high, you are dealing with a load. If it's low, you are dealing with an extra-renal cause, or you can have osmotic diuresis. So again, urinary osmolality and sodium will give you a classical clue in that scenario. So Dr. Vibha will carry forward with the cases in this regards.
Oh, so we have this next case. We have this 3-month-old girl. She was brought to the hospital. She has an altered sensorium, and her sodium level was 170, and potassium was 4.2. Urine osmolality was on the lower side, 110. So I advise the water deprivation test. So Dr. Vidhu, do you agree with this water deprivation test at this level of sodium?
Thank you for the question. So now we have a 3-month-old child, and it is said that the baby has altered sensorium. And we look on to the sodium, it is very high. So whenever the sodium is very high, altered sensorium, we have to correct the sodium. We shouldn't go for a water deprivation test. In case we went for that, we would get a bad prognosis. The child would again become bad, may throw seizures or go into coma, or become unstable, and it can even have a bad outcome.
Yes.
So first we have to, so that is what, ideally we are not supposed to do the water deprivation test.
Yes, ma'am. The water deprivation test triggered seizures in this case.
Okay.
So, ma'am, what should be the ideal approach in this case when we have this high sodium?
So when high sodium is there, we have to ideally correct the sodium. And coming to the diagnosis part, since the urinary osmolality is low and the urinary sodium value we have to see, so then we have to distinguish between the whether it is a central diabetes insipidus or it is a, so if it's central, then we have to know the AVP response.
When we give the AVP and the AVP response was present.
So now it comes to it is a central DI.
Right, ma'am. So, ma'am, what key message would you like to give from this case?
So it's always like whenever we approach a case, we should first see that whether the patient is stable or not. So in this case, we are just going into seeing whether the child, how is the child's CNS general condition. So now we understood altered sensorium, then we point on to the sodium. We already know that hypernatremia is there. So first we are going to correct that. And once the patient is settled, is out of danger, then we can go into the diagnosis part. And as the flow chart shows, we can correctly diagnose the child.
Thank you so much, ma'am. As ma'am has correctly said,
that
at this high level of sodium, like 170 level, advising the water deprivation test could be harmful to the patient, as in this case, it has triggered seizures. So in these type of cases, we should not go for water deprivation tests directly. We should go for the AVP response. And if by giving the AVP, the osmolality has increased, it means there is a central DI. If there is no response, then we are dealing with the nephrogenic DI. So now moving towards the next case, we have this 14-day-old girl who came to us with the failure to thrive. She has lost weight 300 grams from her birth weight. She was born to a primary gravida and she was exclusively breastfed according to her mother. Her serum sodium was 182, which was quite high. And when we did the urine osmolality, it was 1000. So, Dr. Pragya, what could be the cause of such a high sodium in this 14-day-old girl?
So as we can see, this was a 14-day girl born to a primary gravida mother and was exclusively breastfed. Right?
Yes, sir.
And serum sodium was 182. The urine osmolality was 1000, which was this is a hyperosmolar urine with a sodium load, as we can see.
Yes,
so
urine sodium was 110.
Urine sodium was also very high. So this is most likely a case of breast milk hypernatremia, which usually occurs in primary gravida mothers due to inadequate milk secretion. And as the babies are exclusively breastfed, they suffer from a sodium load. It's not that breast milk has a very high sodium concentration, but just due to inadequacy of feeding, they suffer from this condition. This is a potentially lethal condition, and the prevention from this condition is the best modality. So every primary gravida should be properly trained and educated regarding this condition.
Ma'am, what key messages would you like to give?
The message I would like to give is that high serum and urine sodium indicate a high sodium load. And as I said, breast milk hypernatremia is a condition that is seen in primary gravida mothers due to inadequacy of milk secretion, and they should be trained well in advance regarding this condition so that it could be prevented, as it is a potentially lethal condition.
And this is a very, very dangerous condition. So it is recommended that at day 14, we should ideally measure all children with their weight. They should have regained weight by that time. And if you have a child who presents to you with this severe hypernatremia, go for a dialysis. Don't wait and watch, because otherwise there will be acidosis and the whole scenario will really spiral out. So such severe hypernatremia, dialysis, be ready, seizures will happen because you're cutting down sodium quickly. You will have hyponatremic seizures, but don't worry, you give 3% saline, bring it down, because otherwise the child will die. So this is something which is a very, very dangerous. Parents are happy because child is sleeping. They feel the child is sleeping, and urine output, they don't know how much they are passing. So this is a true message. They should look at birth weight and weight at 14 days and whether they are passing enough urine. This is a very, very preventable cause of hypernatremia.
Thank you, sir. Thank you, Dr. Pragya. Now, moving towards the next case, we have this 13-year-old boy who was admitted for encephalitis in the PICU, and he was on the ventilator, and we got a call from the PICU because he suddenly started passing lots of urine. There was polyuria with 10 ml per kg per hour. And the serum sodium level was 180 millimole, and urine osmolality was 120. That is quite low. And when the AVP was given, the urine osmolality increased. So, Dr. Kamlesh, what do you think? What has happened suddenly in this child? What causes the polyuria in this patient?
Thank you, Dr. Viva. As a child is having the encephalitis and is on ventilator, and we are seeing that he has developed hypernatremia with polyuria, and urine osmolality is less than 600 milliosmoles. So we have, as the Dr. Anurag already told, that we look for urine osmolality. If it is less than 600, then we have to look for the AVP response, and the AVP response is there is increase in the urine osmolality. So the child is suffering from the brain death, diabetes, central diabetes insipidus. That has caused the polyuria in this child.
Right, so very well said.
And how do you, Dr. Vibha, why do you think that if somebody develops DI because of brain damage, why is it diffuse? Why is it not focal?
So I'm not getting the question.
Because the AVP neurons are very widely separated. Dr. Kamlesh, yeah.
Sir, actually, the neurons in the AVP secreting neurons are the diffusely located in the 1 centimeter apart in the cortex, and they converge in the pituitary stalk. And if the diffuse involvement is there in the encephalitis, that one can cause the DI. Otherwise, small lesion will not cause the
One
DI.
or two infarcts or other hemorrhages will not cause a problem. You need to have a much bigger insult to cause that. So a sick child developing DI, earlier we used to say brain death DI. The child is, this is a marker of a very serious disease.
Yes.
Thank you, sir.
So I think that's something which is the
Yes,
key
sir.
message is consider brain death with severe and you have to, options are fluid replacement. We don't want to go into too much into that in that way. So when we correct hypernatremia, again, the message is you need to have a slow correction. Over 48 hours, you use maintenance, which is 4-1, followed by free water deficit. For every 1 millimole per liter rise in sodium, there is a 4 ml per kg free water deficit. So then you calculate it accordingly by 4 ml per kg, and then you look at the ongoing urinary loss. You add all of that, give it evenly, you will get the right formula. Now, remember, you don't want a rapid fall. If it's an acute condition, you want 9 to 12 millimoles per liter per day. If it's chronic, 6 to 9. Now, remember, whatever you do, you will have a rapid fall often and you may have seizures. So do not give too little sodium also. 70 to 100 millimoles per liter is usually good enough, around 20% above the maintenance. And monitor sodium very carefully. If you have seizures, what will you do? So Dr. Dhwani, if you have hypernatremia and you treat somebody develops seizures, what will you do? Yeah, so you have a very rapid fall which is causing this seizure. So you give extra 3% saline to carry. If you have hyponatremia and you're having a rapid correction, what will you do? You give free water. So that is the option. Or you give a AVP. So that is a re-lowering. This is re-rising. So you give 3% saline to correct that in that scenario. We have in our application tool which allows calculation of how much fluid rate you want to give in that perspective in hypernatremia, also for hyponatremia. Now coming to the last part of hypokalemia. Hypokalemia can be because of intracellular shift in the setting of insulin excess, because of decay, because of malnutrition, rapid correction of fluid status, beta agonist. You can have intestinal loss, so typically diarrhea, that will be a typical scenario, as well as vomiting. Now diarrhea will cause hypokalemia with acidosis, while vomiting will cause hypokalemia with alkalosis. And then you can of course have a renal loss in which you will have usually metabolic alkalosis because of furosemide, thiazide, or if you have RTA, you will have acidosis. So what is important to remember is that everybody who has hypokalemia usually will have metabolic alkalosis. If you have metabolic acidosis, think of GI loss and RTA. So pH is one of the most important investigations to look at in the setting of hypokalemia. So hypokalemia, as discussed, cellular shift, extrarenal loss, potassium is low. While if you have a urinary loss, your urinary potassium will be high. In this scenario, this could be RAS dependent, in which you will have hypertension, aldosteronism, high aldosterone, or rare forms of Liddle and 11-hydroxylase, which we discussed yesterday. And other scenario could be if you have a situation in which you have a RAS independent situation like tubulopathy, you will have alkalosis, RTA, you will have acidosis and osmotic diuresis. So looking at that, what you're mainly looking at is urinary potassium, and you're looking also in terms of the aldosterone and the renin axis, which will give you a picture. So if typically you talk about hypokalemia, if your volume is high, that is RAS excess. Otherwise, they are usually a secondary hyperaldosteronism. Anybody to have persistent hypokalemia should have a high aldosterone, whether it is primary or secondary. Anybody to have persistent hyponatremia should have a high AVP, whether it is appropriate or inappropriate. So same, aldo will be high, but if you have volume excess, that is a primary hyperaldosteronism. Urinary chloride, again indicating how much loss you are having. pH, as I said, if you have acidosis with hypokalemia, diarrhea and RT. So acidosis really makes it much narrow. Of course, anybody with chronic hypokalemia, anybody with chronic hypocalcemia, anybody with metabolic alkalosis, look at magnesium. This is an important message there, and blood pressure. So approach is look at blood gas. If blood gas shows acidosis, this is either diarrhea or RTA. Look at urinary anion gap. If it's positive, it is RTA. Negative, it is GI loss. If there is alkalosis and you have got hypotension, you're thinking of tubulopathy, or the BP is normal, not high, look at hypercalciuria, that will be Bartter syndrome. Otherwise, it will be Gentleman syndrome. If your blood pressure is high, so you have hypertension, along with hypokalemic alkalosis, you're dealing with aldosterone excess. What is the aldosterone? It's high, it's primary hyperaldosteronism. Aldosterone is low. Look at DOC dependent causes, which will be the CH variants, 11 and 17 hydroxylase. And if they are both normal, so you have got a aldosterone which is low, DOC which is low, renin which is low. So what is happening? You look at aldactone response. If the child responds to aldactone, that is an apparent mineralocorticoid excess. No response is Liddle syndrome. So hypokalemia approach is blood gas, acidosis, diarrhea versus RTA. If you have alkalosis, look at blood pressure. Hypertension, you look at low renin causes of hypertension. Normal tension, look at diuretic versus Bartter and Gentleman syndrome. So we'll carry forward from there, Dr. Vibha, with the next case.
Thank you, sir. We have this 2-month-old boy with hypokalemia, and the blood gas shows acidosis, and the Bayes excess was -16. And when we did calculated the anion gap, it was 12. So we are in dilemma whether it is diarrhea or RTA. So Dr. Sumana, could you help with this condition, whether it is diarrhea or RTA?
Thanks, Dr. Bajpai. That's an easy one because sir just explained to us, as per the protocol, if the blood gas shows that rare combo of normal anion gap acidosis with hypokalemia, very rare one, then we should think of either diarrhea or RTA. Now, I would like to ask, is there any history of polyuria or anything in this baby at all?
No, ma'am, there was no polyuria.
Okay, so I would next like to go on to the urinary anion gap. Then, do you have any reports for me?
Right, ma'am. It was urine sodium was 120, potassium was 20, and chloride was 220. So the urine anion gap was -120.
Correct. So that's a negative urine anion gap. So this again, so going back to the protocol as sir has been explaining all this while. So normal anion gap acidosis with hypokalemia with a negative urinary anion gap indicates probably it's a case of diarrhea. We would like to, instead of RT, we would like to know about the urine potassium creatinine ratio if you have that.
Yeah, ma'am, it was normal. It was not very raised.
So yes, so that is another pointer, that is the loss of potassium is probably extrarenal and not renal. So we have the diagnosis of diarrhea here instead of RT.
Ma'am, what are the key messages from this case?
Right. So like we discussed, that in any case of acidosis with hypokalemia, we should think about the two diagnoses, RTA or diarrhea, diarrhea being of course more common, but then we should not, we should always do the urinary anion gap to come to the diagnosis. That's a clue.
Thank you so much, ma'am. Because differentiating these two is important because the line of management is completely different.
It's totally different, of
Right.
course, of course.
Thank you so much, ma'am. So moving towards the next case, we have this 3-month-old girl who came to us with the failure to thrive with hypokalemia. She had gained only 700 grams in this 3 months. The blood gas shows alkalosis. BP was the BP was normal for this age. So Dr. Vidhu, could you help us with this case?
Yeah, sure. Thank you for the question. So now we have a baby who has failure to thrive. And in the scenario, we almost understand that the baby has persistent hypokalemic alkalosis.
Right.
Now in the flow chart, sir has explained that whenever alkalosis is there, hypokalemic alkalosis is there, next step what we have to look into is about the blood pressure of the baby.
Right.
So I can see that the blood pressure is in the normal range. So once we know that the blood pressure is in the normal range, we are thinking more about Bartter, but to make sure, we have to also see about the hypercalciuria or the urinary calcium excretion. Okay. So whenever in a case of you're suspecting Bartter's at the child, if the child has an early, usually the children will have an early urinary hypercalciuria, or in the scan, you can see nephrocalcinosis, then it almost shows the diagnosis. So we have a child with persistent hypokalemic alkalosis with normal BP and who has nephrocalcinosis or hypercalciuria. So Bartter syndrome.
Okay. Ma'am, what key messages would you like to give?
So the same thing, what I said. So first, when you get persistent hypokalemic alkalosis, first check at the BP. If the BP is normal, then go to the calcium. This by order you are checking. And then if hypercalciuria is there, then it can be used.
Thank you so much, ma'am. So as ma'am has rightly said, if the BP is normal and we have the alkalosis, so we should get the urinary calcium done, and we should get the ultrasound for the KUB done to get the information about the nephrocalcinosis. So moving towards the next case, we have this 8-year-old boy who came to us with the early puberty when the height was 134 and the pubic hair was stage 4. The blood gas shows alkalosis and there was hypokalemia. The urinary chloride was 100 and the blood pressure was on the higher side for this age. So Dr. Pragya.
So Dr. Vibha,
could you help with this case?
Yeah. So the case you have given is a 8-year child with a precocious puberty,
right, ma'am,
and hypokalemic alkalosis, a urine chloride on higher side, and hypertension.
High blood pressure, right?
So here we would first go for, as we have gone already given the blood gas analysis, we have seen the BPs on higher side. We will go for the aldosterone levels. So if the, have we done aldosterone?
Yes, ma'am. Aldosterone level was low.
So if the aldosterone level was low, we will go for DOC and 11 DOC levels. Can you tell me more about external genitalia, Dr. Vibha? Because
yeah,
as
ma'am.
when
we did the examination, it was quite surprising. The gonads were not palpable.
Okay. So most likely we will, if in this scenario, if the DOC and 11 DOC should be high, and we are seeing a case of 11 hydroxylase deficiency, and most likely this is a female who has who is hypervirilized and is being raised as a male, and due to the precocious puberty, she has we have got her now as a case of hypokalemia and alkalosis. So I would say that this is a case of 11 hydroxylase deficiency. 11 hydroxylase is an enzyme which converts DOC to corticosterone and 11 DOC to cortisol. So in this case, as this conversion cannot happen, DOC and 11 DOC will be raised. These have a weak mineralocorticoid activity, due to which these cases are many a times missed in earlier age group and present later with a hypervirilized condition and hypertension, along with electrolyte imbalance, hypokalemia, and alkalosis.
So, ma'am, what key messages would you like to give?
So the key messages in this case would be, Dr. Vibha, that hypertension with alkalosis, we should rule out CAH, as this is a very treatable condition and could be treated easily. And in a XX DSD, 11 hydroxylase defect should be ruled out every time.
Thank you so much, ma'am. As it was discussed yesterday also for the DSD session, the examination of genitalia and examination of the gonads, palpation of the gonads is essential in the cases when we are dealing with hypertension, alkalosis, and the electrolyte imbalance. So thank you very much for this session.
You're welcome.
So I think this was a very, very interactive session on the electrolyte disorders, and we were able to discuss a lot of these disorders. So I'd like to thank Dr. Vidhu, Dr. Sumana, Dr. Pragya, and Dr. Kamlesh, along with Dr. Vibha, who conducted the session very well. We'll see if there are any questions before we wind up the session. So can magnesium levels be used to differentiate Bartter and Gentleman syndrome like urinary calcium levels? So Dr. Bharani, that's a very valid point. But usually Bartter will also be losing magnesium. So they will also often have hypomagnesemia. So while hypomagnesemia is a predominant presentation for Gentleman syndrome, you will have more cramp-like presentation and later onset failure to thrive. It is not the absolute differentiating feature in this scenario. So I would say magnesium levels may be relevant, but most important will be hypercalciuria. So there will be a lack of calcium excretion. So just remember, Bartter syndrome is like furosemide excess. You are losing sodium, potassium, chloride, hypercalciuria, while Gentleman syndrome is like a thiazide excess. So you will not have hypercalciuria, you will actually have hypocalciuria.